Hey guys, welcome back to the Foam Frat Podcast. I'm joined with Mike Boone and old Dan Rauh from Heavy Lies the Helmet. How you guys doing?
Good, man. Good. Thanks for having us.
Yeah, this is pretty special.
Is this the first time that you guys have been on? I know I've been on Heavy Lies the Helmet. We've done some episodes.
Yeah, technically. So Dan definitely, I don't think, has done any official collaboration with you. We did that, obviously, entitled nasal cannula episode, Brian and I, and did that with you, and that's always been a really successful one. But no, this is the first time we've been on Foam Frat, so this is extremely exciting. Obviously, we've chatted a lot, and we had a recent event where we spent some time together, so it's good to come together in maybe more of a professional setting.
Yeah, I'm happy to have you guys on. I'm a big fan of the podcast. You guys have been cranking out the episodes lately. It's been really cool to see how much you guys put out. You're over, what, 105, 110?
Yeah. I think we're going on our 106th episode. Yeah, that's right.
That's awesome, man. Well, what we're going to talk about today is all of our favorite RSI cocktails. And it's interesting. So I was talking to Dan about this because everybody's got, it's like vent settings. You know, everybody has the thing that they think is the best. Oh, I always use pressure control. I always use this. I'm an etomidate person. I use ketamine. I can't think of a patient I wouldn't give ketamine to. And honestly, like, as long as you know it really well and you're very aware of how that medication works, then you're probably fine, right? But I thought it would be fun, and Dan had the idea, like, we should all get on and talk about what is your typical, like, RSI cocktail. So here's what I was thinking. I'm going to paint like a scenario, right? And then we'll each go through how we would get that patient to the point of intubation, how we would make them the best intubating conditions for our partner. So we're not the one intubating. We're the one drawing up the meds. We tell our partner, all right, you got the tube. I'll get them asleep for you, and we'll keep them hemodynamically stable. And, you know, obviously all the resuscitate before you intubate stuff, but I really want to get into the actual medications. And so I want you guys to imagine you're going out and you got a patient that was in a motorcycle accident, and you open up the back of the ambulance as you're getting in, and your partner goes in the side door. They're getting the airway stuff. And this, you walk in, you got like 5 firefighters holding this guy down, and he's screaming, but you can tell he's not really like making sense. He's got a head injury. He's swatting people, and they're holding him down. They got an IV in his arm. We'll say he's got like they got an 18 in. By the grace of God, they somehow got an IV in this guy. And they go, yeah, we can't get him to stay down. He's trying to rip his collar off. And you look at him just to see, like, is he having a panic attack, or is he actually, is he got a head injury? And he's just not making sense. And then you notice that he's got some drool coming down, maybe some blood on his lips. And you look at your partner and you're trying to figure out the best way. You don't even know what this guy's blood pressure is. Nobody can do anything. Somehow they got an IV, but you guys decide we need to intubate him before we fly him. And we're going to do it here. So we'll start off with Dan. Dan, walking in, we've all been in that scenario before. Sometimes we even predict what it's going to look like before we get there. How would you go about taking this patient from the point of needing all these firefighters to hold him down to now he's relaxed and calming the scene down?
So that's a great case, right? Because it presents us with all kinds of dilemmas. I think your immediate reflex is to do the candle moth thing. You just go in and jump on the guy and decide, we're going to do X, Y, and Z, and then do some assessment later. But I think that's what separates the champs from the chumps, is you have to be able to step back and not get sucked into the fury of what's happening in the back of that ambulance, and just get a good look at that guy. And what's your first impression? I think step number 1 is I'll make sure my partner goes in first. so that they get the full experience. I always tell people, after 35 years of doing this, I've had the opportunity to have the full ride a number of times. I don't want to cheat anybody else out of that, so I always let them in first. So I'd get them in there, and then I just kind of step back and get a look at the guy. Is he bleeding to death somewhere? Is there something tragic? If he's got a completely obstructed airway, that would be enough to make anybody freak out, or predominantly obstructed airways. So I just look at those basic things. Does he have something that requires some immediate intervention? And as long as that's not the case, and he's just essentially batshit crazy, and he's got a head injury, and he's just being a wild man, then you have to kind of decide how you're going to handle that situation. I think, I am not a ketamine always guy. I think ketamine has its place. I always think that, to coin a phrase that I heard Sal use once, that if you told somebody you had your favorite antibiotic and you used it on everybody, they'd look at you like you were nuts. But we hear people say that they have their favorite whatever and they use it on everybody. So I am not a ketamine always guy. I am a ketamine most of the time guy.
Say Zosin entered the chat.
Right. Yeah. Nobody gets out of the emergency department without a dose of Zosin. If they're really sick, it's Zosin and vancomycin. Nobody gets out of there. Or as my partners call it. Yeah, right. As my partners call it, wancomycin. So, I'm going to get a look at the guy, make sure the IV is good, because not all IVs placed in people who are crazy are actually inside of the vein. And if you didn't know that, it's really important that not just the catheter be inside the skin, but it actually be in the vein. We've all been burned by that one, right? Where the IV is good until the drugs never take effect. Then we realize maybe it's not as good as we thought it was.
I had a friend one time. I was like, hey, is your IV good? And he goes, well, put it this way. I wouldn't give anything you wouldn't give sub-Q.
Right. Because the person who sticks the needle in and then throws their hands in the air and says, all right, I got it. That's the only one that really believes in the IV. Everybody else is kind of like, is it really good? So I always call it my power flush. I do the power flush to make sure it's really good. Assuming all those things, I think I would probably whack this guy with a good dose of ketamine just to get him on the same program with the rest of us, get him chilled out, give us a chance to take a step back, potentially oxygenate him or pre-oxygenate him if that's what we need to do, and get him into his optimal intubating position and condition. So I would first, I think, give him a dose of ketamine. And my dose for a guy like that, somewhere between 1 to 1.5 milligrams per kilogram. Certainly no less. I know there are lots of people who are really dogmatic about these doses of drugs. And let me just raise the first point for discussion, I guess, between all of us, is that the only thing I could say to you when you're dosing these drugs is, if you are that particular about, is it 78.5 milligrams of ketamine, or is it 82.5, or is it 90? You probably need to go into transplant medicine, because
especially when you're guessing the weight.
Right. We're not building cabinets here, and let's face it, anywhere between 1 to 5 milligrams per kilogram of ketamine is an accepted dose, depending on the indication, right? If you're given an IM, there's lots of people that swear by 5 per kilo for somebody who's dangerously psychotic. So I would go somewhere 1 to 1.5. And how I would achieve that is I just look at it and go, he looks like he's about 100 kilos. And let's give him 150 milligrams. And that'd be my first step.
And if it's not enough, then you give more.
That's right. It's very hard to ungive it. I've seen people try that with push dose epi when they didn't realize that push dose epi is something you mix in a syringe, not that you give out of the Bristojet that comes in the code cart. And I've seen them try to aspirate back on the Bristojet, trying to get it back because somebody said, no, I didn't mean that. You get too much. Like, they're trying to get it back out of the tubing. So it's not as effective as we'd hope.
Yeah.
What about you, Mike?
No, yeah. I mean, I think ketamine's a great choice in this. I always think of this scenario when I don't have IV access, and I think intramuscular is a great route for that, especially if this is a safety risk. Obviously, people are in the fire line as far as what this patient might do. So I think you do have to act fast. You bring up a good point, Tyler, as far as not knowing weight in the pre-hospital setting, especially on a scene. That is a dynamic that I think is extremely important, because people get very focused on weight-based medications, as they should, especially in the case of ketamine. But we also have to do it with the realistic expectation that that's an estimated weight. I think that erring on the side of more if ketamine is good, because we want to avoid that partial dissociation range. And I think that's really what you get into if you start to get, that sub 1 milligram per kilogram. So I think definitely 1. Me personally, I usually go immediately to 1.5 for that reason. So in my case, verifying IV access, maybe there's a paramedic there that can work on a second site, because if we know that we're going to have to establish an airway in this patient, the last thing we want is for them to receive half of our ketamine dose and then our IV goes bad. And then here we are scrambling, trying to get meds in this guy who now doesn't have access and now maybe even partially dissociated. And maybe now we have an even worse scenario on our hands. So I think first and foremost, having somebody work on that and then going on the higher side of the ketamine dose, 1.5 mg per kg IV, and then have that essentially be my induction. Now, the other thing you have to consider too is your duration of action. So is your partner completely prepared to go ahead and initiate the RSI sequence? If not, it may be a situation where you're going to end up having to redose this patient, or as Dan alluded to, maybe even giving them a little bit more if we're trying to achieve full dissociation, getting that sedative effect so that we can then follow it up with paralysis.
Yeah, I mean, I agree. I'm totally on the ketamine train. However, I think my strategy is just a little bit different. So this is like the ultimate DSI scenario, right? You need to facilitate oxygenation, pre-oxygenation, figuring out what this guy's blood pressure even is. Like, you need to do all these things to make sure that you're not just rushing in and trying to intubate them, right? We want to be able to assess them. And so I always tell my partner when we're going into an accident or something like this, hey, if we get in the back and everybody's holding this dude down, it's chaotic, he's swinging around, I'm giving him 300 milligrams IM ketamine into his thigh. And the reason I prefer IM, even if they have an IV, I'll still go IM because not only am I not really sure, like Dan said, like, is that a good IV? But you're inherently going to push it too fast when somebody is trying to like come at you and like, you're holding them down. And so I find that the IM, 300 IM, it has a built-in slow infusion, a built-in slow rate that you're giving it, because I've seen people give it too fast IV, and then all of a sudden they got laryngeal spasms, they're hypersalivating, and now you have all of these negative effects. And everything we know, the majority of the negative effects that happen with ketamine happen when you push it too fast. That's when they go apneic, and you have to start bagging them. I found that I get the perfect, nice, slow push effect if I go 300 right in the leg, IM, then all of a sudden they start relaxing, right? And they have to hold them down for just a little bit. It kicks in. They're still breathing. They still have their airway reflexes. And it's just like you can just hear the whole scene go and like calm down a little bit. And then I still have 200 because we have 500 milligram vials. I'm guessing that's what you guys carry too. Yeah. So then I still got 200. And we go through, we put the nasal cannula on them if we have to bag them, or non-rebreather, get everything set, go through our RSI checklist. And then when we're ready to intubate them, we're going to push our paralytic. I'll push like another 100 milligrams of ketamine, and then I'll give them, 100 or rock or something like that. And as much as you could say like, well, 300, you have to go by 4 to 5 milligrams per kilo or 3 milligrams. I have no idea what their weight is, but I know that the average size adult, this is mostly for adults, 300 milligrams is going to get in. It's going to take them right where I want them. And the biggest thing that I may see if I gave a little too much is just how long it lasts. Maybe it lasts a little bit longer. It's kind of like a Tomidate, where if you give a little too much, it just lasts a little bit longer. I'm not worried about it. The safety profile for ketamine is really, really good. And I got to get this patient to a point to where I'm in control of the scene and no one else is setting that timer for me. And so I'm a big fan of that initial IM dose and then getting the IV, making sure the IV is good. If they already have the IV, flushing it, and then giving, 100 or so right before we actually go through with the intubation. What do you guys think about that?
I think that's one of the crazier things I've ever heard. And I'll tell you why. I'm a firm believer there's lots of ways to skin a cat. And if my partner was really locked onto that, I guess I'd probably shake my head a bunch and kind of wring my hands a little bit and go, oh my gosh, I don't know if I'd go, wait a minute. So I think it probably would work in a lot of cases, right? My concern is, what do you do when you get that first blood pressure and now it's 60 and you realize, holy shit, he's probably got terrible circulation or at least diminished perfusion to his wheels. And I've not given tons of IM ketamine, but I mean, what kind of absorption are you seeing? Like, how long until he's a guy that you want to take to a dinner party with you?
I mean, honestly, the amount of times I've done this, I don't want to get into, in my experience, I see this kick in within, under 3 minutes, 3, 4 minutes. I'll see it kick in. If you're worried that they're not perfusing, but here's the thing, a guy that's like that has a head injury and is combative and usually their blood pressures are pretty, they're on the higher side. They're very I hate to use the word hypermetabolic, but if I'm thinking it's a head injury and they are perfusing well enough they need 5 firefighters to hold 5 of them to hold them down, I have to know what their blood pressure is. I have to get to a point to where I can even do an assessment. So if I get to the point where 300 milligrams of ketamine, you're saying that's what dropped their blood pressure, or you're saying that's what their blood pressure is, and so it's not absorbing?
No, I'm saying that's what their blood pressure is. And I agree with you that most people who are wild like that, hypotension is not their predominant problem. So what if you just give it, 150 IV, and then if the IV is bad, then you're still not far from where you would be by giving it IM.
Well, I don't know. I mean, it's not going into a muscle if the IV is bad. If they put the IV into a muscle, then that would be impressive. I'm not giving it sub-Q, right? So we're giving this IM. You're giving it right into a big muscle. And if my intuition is that they have plenty of perfusion in that, which is what I typically see, then yeah, I'm not worried about it. Now, I don't have any problem with giving it IV. I just have seen people frack that up real bad because they're stressed and they push it too fast. If you can sit there and push it over the course of a couple minutes and give that, that's fine as long as you don't do a rapid flush afterwards. But, if you can do that, then that's great. But typically I'm like, no, hit them with 300 in the leg. And you guys keep doing what you're doing. We'll start setting up for intubation, and it just gets them to a spot to where they're just relaxing. And maybe you get to that same spot giving it to them IV, and you're not always going to have them go apneic and be like, oh crap, we got to get all the stuff out, or oh, now they got all these salivations. But I just find that it works really, really well at taking control of the scene. And a lot of times they don't have an IV, right? Because nobody's been able to get that IV. So my mental model of how this looks when I do it is very predictable. I mean, it happens the same way. And that's why I wanted to throw this scenario out there, because it is something that I now know before we even get there, this is what we're going to see. I mean, it's HEMS, right? We deal with motorcycles, snowmobile. It happens all the time. You get there and somebody's got all these snow pants on, and I like to hit them with it. Now I've seen people try to do intranasal, and I think that is the craziest thing I've ever heard is intranasal on somebody like that, because the amount that you need to give to get them even remotely to a spot where IM ketamine or IV ketamine is going to make you want to take them out to dinner, like you said. That is you're not able to do that. You retire, I feel like, from intranasal medication in like elementary school, because you just can't get the same concentration of drug that you need in less than, 1 ml per nair or something like that. So I do think intranasal is ridiculous, but I do like IM, at least for that initial one. Now that's a very specific type of patient population. That's the one where I really do like ketamine, because I want to facilitate the pre-ox period. It's a procedural sedation, with that procedure being the pre-ox period.
Yeah. Obviously both of you are right and can be justified in that scenario. I think that it's really important to have clear goals in mind. And I think a lot of times that's what's going to determine your route, because to me, I see that scenario as this person has a patent airway. The RSI necessarily, even though we know that that's going to be part of his clinical course, that's not what he immediately needs. And so I think IM ketamine in just any psychotic patient in general, I think is a good approach. Oftentimes people will refer to this as a harpoon. It's that high dose of ketamine IM, because it is very effective in this patient population. And if it buys you time in that scenario, I absolutely do think so, because I don't think that a RSI needs to be rushed necessarily. I think it's just important that if you're doing that, you remain cognizant of how much you're administering so that you can follow that up appropriately with your induction.
Mm-hmm.
So I like your idea. I like the mental model idea. And I like, if they don't have IV access, I think to know going in, here's the plan. If he's wild and he has no IV access, we're just going to jack him with 300 of ketamine, and then we're going to do all of the other stuff. I think that's a fantastic idea. I guess maybe you and I just differ a little bit, which is cool. There's lots of different ways to do that. I would probably lean, like I said, towards giving the IV drug. And if he quits breathing, then we'll just bag him up. I'm pretty comfortable in my ability to bag somebody up. And he probably wasn't hypoxic to start with. So it's not like he's going to, like we do see with some inductions where they're on their way to unconsciousness, but their SATs go first before their mental status goes, right? And then we're trying to like oxygenate them while they're still kind of looking around and moving their head. Place to be. So with him, I think that's not going to be a problem because he's probably hyper oxygenated because he's a wild man back there. So, but I think you present an interesting concept, especially for somebody with little to no IV access or really questionable IV access. I want to just take a step back for a second, something that we talked about a little bit, and I'd like to encourage people to think about is make your life simple when you're dosing drugs. When you're guessing somebody's weight, I guess them in increments of 10 kilos. Nobody weighs 75 kilos. They weigh 70 or 80. And you just make your math much easier. Because I've seen people in our CCTA program doing orientations. I've seen people paralyzed by decimal points and paralyzed by small integers. So as soon as you say, let's give he's 76 kilos, especially if you're in a hospital where they have the beds that calculate the weight for you. They're like, he's 76 kilos. And you say, let's give 1.5 per kilo. You'll see people glaze over, right? Because they're like, oh shit, 1.5 times 76. Oh my God, So if you incorporate into that mental model, he's not 75, he's 80 kilos. And then let's give 1 per kilo, so that's 80, and then we'll cut it in half. That's 40 more, make it 120. Just someplace, like General Patton said, never come up with a plan so ingenious the troops can't figure it out.
Yeah, no, I totally agree. You and I were talking about fixed dose paralytics, and Joey Lerner's skin's crawling right now because he hates that idea. But I don't see a reason that you couldn't just be like, yeah, let's do 100 of rock. I mean, an average adult size, let's do 100 of rock. Let's do 10 of VAC, right? That's what I do. I mean, I go in, I'm like, yeah, 30 of etomidate, 100 of rock. If we need to give something else, we can. But that's generally where you'll see, there's a study that says you need to give 1.2 milligrams per kilo, and you'll get better intubating conditions with rock or similar to succinylcholine. No, just give them 100 of rock. And if you need to give more, then we give them more. But like, I offload that. And it's not because I'm wanting to be lazy, but it's because I can only make so many really good decisions on a call, right? I mean, I am going to have to watch like the scene and like the scene I was just talking to you guys about. Like, there's so many things going on. Your bandwidth can't waste time coming up with math and equations for things that honestly really don't matter. And so I did a thought experiment blog on fixed dose paralytics, and it was, a little hyperbolic, and I think where it really comes into play is with like kids and stuff, but you're already doing the math with kids. You set yourself up, you're busting out the calculator as soon as you know you have a peds call. Save it on the adults. The adults, you're going to be fine. If you give them too much of a paralytic, guess what it does? It just lasts a little bit longer. I do think about dosing considerations a little bit more in the hemodynamic, like compromised patient, because I think of everything in the body, like all the vasculature is shunting everything to like the brain and the heart and the vital organs. And so your normal volume and distribution for your drugs is not normal, right? Everything has got a shortcut right to the brain, because that's where you're wanting to get it, is the central nervous system. And so you don't need the same dose because it's not floating around everywhere like it normally would when they determine that dose. It's going right to the central nervous system. And so that's why you see like the same brain levels of, propofol at like a 90% reduction in some of the lab studies that they've done. Or instead of giving 200 of ketamine or 150, maybe you find that you only need 50 or 100. You lower those doses down. But then you also see people increase the dose of their paralytics because those actually do got to circulate around. Those don't have a shortcut right to the right to the central nervous system. And so I remember Josh Farkas did a post about how you can almost guess somebody's cardiac output by how long it takes for those paralytics to actually kick in. And so that's where I will think about, oh, I'm gonna increase my dose of this a little bit more, or I'm gonna reduce the dose of my induction agent. And you can get into the whole, well, this is the best drug for the hypotensive patient, but in reality, it's what's that saying? The difference between medication and poison is the dose. And I really believe that to be the case when it comes to induction agents. There's not one drug that is for hypotensive patients. Like, I don't buy it. I know that's how it's sold, but that's not my mental model. And so maybe that could lead us into the next discussion is the hemodynamically compromised patient that you do need to take their airway. You do need to intubate them, and their blood pressure's low. They got an elevated shock index, and you're sitting there trying to figure out, all right, if I take away their negative pressure breathing, which is probably the only thing keeping blood coming back to the right atrium right now and keeping them somewhat, alive and having a map. If I take that away, you want to resuscitate them first, but how are you going through and deciding the dose and the agent and how to go about that in a patient? And let's do a septic patient who's like, I don't know, the map's like 50s, 45, 50, they're tachycardic, and they're not protecting their airway anymore. Pneumonia. Pulse ox is like, I don't know, low 90s. You walk in, they're on BiPAP, but they're like this in the chair, like on BiPAP. How are you working through that one? You want to start, Mike, on this one?
Yeah, I mean, like you said, I think when we think of hemodynamically unstable patients, people always want to say, well, ketamine's the hemodynamically friendly induction agent. So that's what I always administer on hypotensive patients. But just like you were alluding to, sometimes these patients only have a blood pressure because they're sympathetically driven from their discomfort or pain. And the moment that you take that away, even though we're not having a negative inotropic effect, like directly like propofol or something might be, with that ketamine, we're still going to potentially lower their blood pressure. So then comes the discussion of, well, we know that we're going to have to paralyze this patient. We know that they can't vomit, and we have to make their muscles appropriately able to accept a blade and an ET tube. So they have to be paralyzed. Now is the discussion, maybe we need to consider a lower dose of our sedative. And I think especially in a patient with a low flow state, when you're just thinking about the pharmacokinetics of that drug, I think that going lower dose on your sedative and higher on your paralysis is very much indicated in this scenario.
Yeah, totally. Dan, you on the same page?
Yeah, absolutely. That's every day in my life in the ICU of intubating people who are in septic shock, who have low MAPs, who have failed other modalities, and now we need to make a more definitive approach. I think my first step for that patient is I'm going to put an ultrasound probe on them and see what their volume status is. Mm-hmm. And I'm going to try to fill their tank as much as possible. I'm going to look at their LV and see if they're hyperdynamic. I'm going to look at their IVC and see if it's completely collapsible, if it looks like a billows on the fireplace, and do my best to tank them up. And then I'm complete in agreement with Mike about lowering the dose of the anesthetic. There's a really good podcast on MCRIT done by a guy named, obviously Scott Weingart, but a guy named Rick Dutton, who was the director of anesthesia at Shock Trauma. And he talks about people who are in florid shock. He's talking specifically about hemorrhagic shock, but the biochemistry of shock is very similar, whether it's hemorrhagic or it's distributive. Is that the way neurotransmitters are activated, that you can use substantially smaller doses of anesthetic agents. And he was talking about doses like 10% of your standard dose. So we're talking about, somewhere between 2 to 8 milligrams of etomidate for people who are potentially in shock like that. So I agree completely. Load up on the paralytic, and if I'm using sucks, I probably go right to 200, as long as I know they don't also have an acute kidney injury and they're not hyperkalemic. If they are, which is certainly worth checking.
They have
If I'm
narrow
using-
angle glaucoma, so
Right. Yes. Right. I will bring out the tono pen and get pressures. If you can get that damn thing ever to work. Anybody that's worked in an emergency department, all you ER nurses out there know about the wonders of the tono pen, that you have to calibrate the thing and then it will never calibrate. You want to hurl it across the emergency department. So, but that, alas, I digress. So, and then with respect to paralytic, remember that there's a difference between competitive and non-competitive neuromuscular blockers. Competitive neuromuscular blockers are very much dose dependent up to the maximum dose. Succinylcholine is competitive. So the more sucks you give, the longer the duration of paralysis, absent and aside from pseudocholinesterase deficiency. But with non-competitive, those drugs are not dose dependent with respect to duration of action. So you could give everybody the max dose of Norcur or Vecuronium. You got now, Tyler. You planted that drug in my mind. Now I can't get it out of there. Of Rocuronium.
Vercuronium.
Yeah, right. Vecuronium in my mind is a drug looking for an indication. I'm an anti-Vecuronium guy.
You just don't like reconstituting it, huh?
Yeah, well, that, and there's two non-depolarizing in my mind. There's cyst, which is what we use for ongoing paralysis in the ICU, and there's rocuronium, which is an induction drug. The difference between the two is vecuronium does not avoid Hoffman metabolism and can actually make people worse long term. So, but nonetheless, so I would give a strong 1.2, and the way I come out with 1.2 is I just upscale their weight. So I just look at him and I'm like, he's about 100 kilos. Let's just make it 120, and then we'll go 1 per kilo. So, but I agree with you. Much lower induction agent, much higher paralytic. Because the last thing you want to happen when you got a hunk of metal buried in their throat is to realize they're not completely paralyzed. Now they're gagging and they puke right when you get a look at the cord. So,
yeah. Well, and insert the discussion about pressors, not to go off on a tangent, but ketamine or not as our induction, even at lower doses, if we're expecting hypotension, we should already be addressing that. We know they're going to require some vasoconstriction. So I don't know if you said if the patient was already on a pressor, something you may want to consider titrating up, or obviously push those pressors as well, just for that peri-intubation phase.
Yeah, I agree totally. And I like Dan's approach of doing the ultrasound, because then you can sort of look, see, are they volume down? How much volume have they had? There's a thought process that if you have a collapsing IVC, that always means that they need volume instead of pressors. And that's not necessarily true, because if you're vasodilated, you just aren't. It's a problem with getting blood back to the heart as well. Right. So figuring out a history of how much fluid have they had, are they on pressors? And then I'm a fan in this case of going, hey, let's just start a levofed drip, because if we need it before the intubation, there's a good chance we're going to need it after the intubation as well. The other thing that's interesting about this one, and Sam and I have talked about this a little bit, is when you have a patient who's already on BiPAP or CPAP, you're getting a little sneak at to what they look like on positive pressure ventilation. And I found that typically it's not as a drastic drop as you taking someone like us right now with negative pressure breathing and then intubating us. That you're going to see a pretty precipitous drop in blood pressure. But you take somebody who's already on, a BiPAP or whatever, and they're on 15 over whatever PEEP, they're already on that. And so that's not something where I'm like, oh man, they're going to drop even further. If they're doing okay blood pressure wise on non-invasive, I'm looking at that going, that's probably going to be around where their blood pressure is. The only variable I'm throwing in there at this point is maybe some vasodilation, dropping the sympathetic tone a little bit. But as far as the positive pressure goes, I'm getting a nice little sneak as to what that looks like. And then, just, I like just starting the drip right away, starting a levofed drip right away. So that way you're not sitting there, all right, give another bump. And then you're just doing that. It's easier for me just to offload that. All right. I think that's all I got on that one. Anything else you guys want to add for the hemodynamically? Oh, one more thing. I've seen it before where you have a patient who's got a low blood pressure and you resuscitate them and get that pressure up. You take that shock index and you start to correct it a little bit. And then people want to use the same dose that you would have in a person who's not in a low flow state. And I think a lot of these situations, you're still in that shock state. You just increase the blood pressure. And so let's say we started off at a blood pressure of, I don't know, a map of in the 40s, and now I get up to like 55, 65. In my head, that doesn't make me go, oh, I can give a normal dose of my sedative now, or I can give a normal dose of my paralytic. I still am dosing it around that low flow state, because just because you squeeze a little bit more doesn't necessarily mean that your flow is better. Is that the same for how you guys think through this? Okay.
Yeah, I agree. Can we talk for a minute about vasopressors? Just because it comes in a damn pre-filled syringe doesn't make it the appropriate vasopressor. I will admit to being somewhat of a hater on phenylephrine. It's not really a vasopressor. It's a downstream creek squeezer that doesn't really give me what I want in a vasopressor largely, which is some inotropic support. So in my mind, take the extra couple minutes to mix up the epi drip or the epi push dose and use that for your push dose pressor. I just don't believe that phenylephrine is really what you're looking for when you need real vasopressor support. What do you guys think?
I agree.
Yeah, I mean, it's a pure alpha agonist. So, excuse me. So if you're just thinking about its mechanism of action, that's all you're getting with epinephrine, especially at a lower dose. You're still getting some beta agonism. So that's ideally, you want to get both if you can.
Yeah, when I think about giving just neosynephrine, like if you're not looking at the heart, you don't know what the heart's doing, and then you're just giving this alpha agent,
spike in their SVR.
Yeah, exactly. And that's what I worry about is, I know that there's some agencies out there that carry just neosynephrine, and they aren't looking at the heart. They're just giving that agent for medical and then vasopressin for trauma. And I feel like medical is probably not the place to just do neo. Like, I would really want to know, am I increasing the inotropy in proportion to what I'm increasing the SVR? Because then that makes me feel better. And that's why agents like Levafed and Epi make me feel better, because, yeah, I'm increasing the SVR, but I'm also increasing the inotropy a little bit more. Obviously with Epi, you get maybe a little bit more on the inotropy side. So I totally agree. I'm not a fan of neosynephrine. I know CRNAs, anesthesiologists love it. They know how to use it. They probably have a really good mental model with it. I don't, and I've never worked for an agency that's actually carried that as well.
Yeah. And when you're talking about these type of patient populations, whether it's, shock index in your hypovolemic patient or, septic shock, we know that over the course of their stay, we're not fixing them by just bringing that map up, whether it's requiring surgical intervention or just the fact that they're going to need support for a longer duration of time. So kind of going back to what you were saying before, keeping that in mind is very much dictating my follow-up, whether it's post-intubation sedation, analgesia. I'm still decreasing that dosages again, just in consideration of that.
Perfect. All right, next one, last one. So you got a patient, head injury patient again, but this guy is out. He's completely out cold. And you get in, he's maybe like snoring respirations. They already have a nasal cannula on. They're bagging him. And his blood pressure is like 210 over 140, we'll say 210 over 190, something like that. Really hypertensive. Heart rate is down in like the 50s, 60s. So you're suspecting he's got increased ICP, and you need to intubate him. What are you doing in that situation? You want to kick this one off, Dan?
Sure. Yeah. So my general approach to this guy would be, I would probably use something different than ketamine, not because I think ketamine increases your ICP, because the evidence is pretty clear that it does not increase your ICP.
Yeah.
It can, however, because it's a sympathomimetic, it can jack up your blood pressure a little bit. And if I think this guy's got a head full of blood, then jacking up his blood pressure is probably not in his best interest. So for a guy like him, I would be inclined to use something like etomidate. There's been a lot of good evidence lately that's all over the board that says that even in people who are shocked that we're intubating, that ketamine is not necessarily the panacea we thought it was, that people have increased mortality with ketamine use over 14 days, that the mortality is lower with etomidate. The studies are all over the board, and the quality of evidence is all over the board too. But in summary, I think etomidate maybe is a little better choice for this guy. And that's probably what I would use for an induction. But I just want to be clear so that the interwebs don't light up with Dan Rouse says that ketamine increases intracranial pressure because my homies at UC, especially Chris Zammit, would probably have his own stroke if he thought that was actually what I believe. So it does not increase ICP. I just don't want to jack up the blood pressure anymore.
What about you, Mike?
No, I totally agree. Ketamine, it promotes the release of...
Oh, very clever. Very clever.
No, I 100% agree. Ketamine is obviously going to promote release of catecholamines to a certain degree, but we really aren't concerned about that until we're getting significantly high hypertension. This guy, 210, greater than that, 220. I also would stay away from ketamine in this patient. Now, the head injured patient, or just neuro in general is kind of a unique discussion because we think about what are the requirements. Yeah, we don't want to increase our ICP, but at the same time, we also have to think about maintaining cerebral perfusion pressure. And we know a big part of that is mean arterial pressure. Mm-hmm. So if we're significantly dropping that, that's why these patients often, you may see them on an antihypertensive coupled with a pressor just because they have very tight blood pressure parameters depending on the neurosurgeon or whomever at the time. So we certainly don't want to drop their blood pressure significantly just to maintain CPP. But at the same time, if given appropriately, if dosed appropriately, etomidate, I usually do 0.3 milligrams per kilogram. That would, in this scenario, would be my choice, just being mindful of the fact that, yes, we don't want to increase their blood pressure, but we also don't want to drop it significantly as well. Yeah. Is there a perfect agent? No, I don't believe there is a perfect agent, but I think etomidate's the right choice here.
Yeah, I like to go I am etomidate. I'm gonna Mike, did you see your phone? I texted you.
No, I haven't looked at it. Let me see.
Oh, I said I'm gonna mess with Dan and say I am etomidate.
That's beautiful.
He's gonna.
You might see his head explode.
Okay, no, I love etomidate. That's exactly what I would do here. I'd probably just give like 30 or 40 of etomidate and 100 of rock. And then my biggest pet peeve with etomidate and rock is that it's etomidate and rock. So your rock is going to last way longer than your etomidate. So typically I'll already have the propofol like ready to go. It's on the pump, and then I'll just plug it in. We'll do like a 0.5 milligram per kilo propofol bolus, and then I'll start them off at like 30 to 40 mics per kilo per minute. If I don't want to get them on the propofol right away, I may use something like Versed until I get out to the ship, but I like to put them on a propofol drip, and then I follow that with 100 mics of fentanyl.
So
now, Dan, go ahead. What? What?
So remember that. I mean, I just think about. So we all agree that a whack of etomidate is probably a good induction agent. Yeah. So now we have a dose of something that's going to cause their blood pressure to drop a little bit. Then we're going to put them on positive pressure ventilation. Now they're at risk for their blood pressure to potentially drop a little bit more. If we get too aggressive with the propofol, pretty soon we could have somebody with a blood pressure in the 120s over 80s. That started in the 240s over 120s, and his cerebral perfusion pressure has just thrown up all over the back of your ambulance. So my general approach, and I certainly don't fancy myself as a neurointensivist by any means, is to have all the toys ready, give them the etomidate, put them on the vent or bag them, and let's see what their blood pressure does, see where it goes. And then I know how aggressive or not aggressive I can be with my sedating agents post-intubation. I am a super strong proponent. of rapidly administering propofol or fentanyl or something to people post-intubation, because I think too often the post-intubation sedation package is forgotten. And then my joke is that, especially in the emergency department, we intubate and then we disappear to go do a pelvic exam or to suture somebody, and we leave the nurses to hang on to people who are climbing off the bed because we didn't offer post-intubation sedation. Now they're searching all over the emergency department for you to try to get an order for those medications. So if you're in the flight environment, it's a little different because your eyes on and right in front of that patient the whole time. So I just would caution people who are not using IM etomidate that just be cautious with loading up with all those negative inotropes and pretty soon you have yourself a normal blood pressure when you don't really want that.
Yeah, I mean, theoretically, I agree with you that propofol can drop your blood pressure. My experience that I've seen is that it doesn't drop it that much. If I'm starting off at 30 mics per kilo per minute, I'm given 100 of fentanyl. And then typically when you pick these patients up from the ER, they're on propofol, they're on nicardipine, they've gotten a dose of labetalol, and they're trying to get their blood pressure down a little bit because it's so high. And typically, what do you see? Like 160s, 170s, somewhere around there is where they like to keep it in that range. But when I get in there and it's 2 something over 110 or whatever, I got a little bit of room there, and I'm not going to give them a lower dose of something like, let's say I give them like fentanyl or midazolam, and then I start a blood pressure agent on them. I'd rather get my blood pressure somewhat, I won't say controlled, but if my blood pressure is going to come down initially, it's going to be because I'm taking care of their sedation and I'm taking care of the pain and stuff. And so I like that cocktail there. I can predict pretty well as to where it's going to land me. If I get in the back and it's 180 over 70. First of all, that guy's not doing anything, right? He's laying down. So all of that blood pressure is coming from his body jacking up SVR, trying to perfuse the brain. And so and I can't tell you how many times I've walked into a hospital and they have a patient on nicardipine and they have the patient on, whatever, some other blood pressure agent. And you go, oh, what did you guys intubate with? Oh, etomidate and rock. And his blood pressure's been sky high the whole time. So that's why I like, and propofol is it's got neuroprotective properties. They can titrate it down and do a neuro assessment on them. If you think that where I will like maybe split hairs a little bit is that initial propofol loading dose. So if I think that this patient's blood pressure is going to come down, right? So we cycle the blood pressure after the intubation. Your etomidate lasts 5 to 6 minutes. It's not going to last very long. So cycle that blood pressure. That blood pressure is still high. Yeah, let's go ahead, do 0.5 mgs per kg of propofol as a load and then start the drip. Otherwise, you can just start the drip and let that run and see where that gets your blood pressure. But typically, if you do that, you're going to find that they start coming out of the sedation, and then you got to go up on your propofol, and you're playing the yo-yo game a little bit with that. And that's where I think like the 100 mics of fentanyl is a nice little buffer just to get that in, or whatever 1 mic per kilo, you're assuming that they're going to be somewhere around that range. But I don't, and we're talking here, I feel like this type of conversation is based off of not textbooks. It's not based off of, what the National Registry says to do. It's not based off of anything, but if you did this tomorrow, what are you doing, right? What does that look like for you? And I don't want to say expert level because I don't think any of us claim to be experts on any of this, but it's our current workflow. And that's why when Dan and I were talking about this, it was interesting because your workflow, you don't do workflows that don't work, right? You do things because you can predict them and you know that it works really well for you. And you've seen situations where stuff doesn't work. And so if you have a workflow, you do it because you feel like it's efficient. Now, that doesn't mean that you can just go completely off of anecdotes and say, the last time I pushed bicarb, I got a pulse back. So it always works. But typically after, I've been doing this now coming up on 15 years, 14 years. Mike, how much experience do you have now?
2008.
2008, and Dan, I mean, you probably got socks older than me, and Mike,
yeah, my back brace is older than that.
Nobody goes and nobody intubates somebody and says, "Hey, last time I gave this, it caused a lot of hypotension. Let's do it." Like let's slam propofol because this always works, and it always drops their blood pressure. So that's what's interesting, is to hear the different arguments for why people do the things they do, but then to watch them do it. And you may pick up on one little thing that they're doing differently, like saying, "Oh, I'm going to omit the propofol loading dose and just go straight to the drip." That could be the difference between somebody becoming hypotensive and not. So it's very interesting to see the different flows in that. We went through Mike and Dan on that one, right? I didn't skip anyone, right?
Yeah, I think for the most part, I have a couple things I did want to say just to follow up with your propofol. I think that one of the luxuries of doing some of these other therapies, induction and RSI kind of are an exception to this, but I mean, we have some things we can assess, but for the most part, when it comes to drips, we're titrating to effect. I mean, that's the biggest thing. And with propofol, it's really nice because of you had alluded to its short duration of action. That's what's really nice about propofol. And if you dose it appropriately, you can make those subtle changes and kind of find that sweet spot, with the caveat, of course, that we're obviously trying to avoid a paralyzed, non-sedated patient, which is what would happen in that scenario, which is why we have to get on the post-intubation sedation quickly. I like the idea of at least giving a little bit of fentanyl, because propofol obviously doesn't have those analgesic properties. And again, going back to a comment we made before, it's amazing how quickly patients' blood pressure can drop just by giving them pain control. So keeping that in mind, that to me, that's a priority for me. Obviously, I want to get this patient sedated, but following that up with pain control, especially if we've used etomidate as our induction agent, they need analgesia. I mean, that's just the fact of the matter. So I would honestly lead with that and then go to my sedative and reassess. We don't have quantitative measures like BIS monitoring and Train of 4 like you would in the ICU or the anesthesia world, where you can really dial in some of these things. We just have to base it on assessment. If we're masking those things, I just know that my patient needs pain control. They've undergone a procedure where they haven't received any. And then that's where I would come up. And I don't hate propofol in this scenario. Honestly, a lot of neurologists like propofol for a lot of these reasons, especially if you've got one that wants to assess your patient. Like you had also alluded to, you can back off that because they tend to not like us dropping off, patients that are very sedated and paralyzed, and then they can't do that.
You bust out that sugar medics.
Yeah. Yeah. So that would maybe be my only slight differentiation there, but I would lead with the pain control, and then propofol, whatever. It honestly doesn't matter to me as much at that point.
It reminds me of like when you go in for like a thoracic aneurysm or abdominal aneurysm. Usually it's a thoracic aneurysm, and like they have all these blood pressure agents on, but they're not giving anything for analgesia. And then you give them like a slug of some sort of medication, fentanyl or Dilaudid or whatever. And then all of a sudden they start peeling off all the agents. That pain is such a huge driver of tone that I love that idea. And I feel like as soon as you get them in, even if it's ketamine, I feel like we sometimes overstate the analgesic effects of ketamine. I think it does have some, but I'm not opposed to giving fentanyl with ketamine. Obviously not together, but if I've got somebody that's intubated and paralyzed on ketamine, I'll still do 100 mics of fentanyl just because, or I keep saying 100 mics, but somewhere around that range, just because I feel like I really want to make sure that that's covered.
Yeah. Yeah. We made a joke on our last podcast actually, but Dan had been asked what his favorite antihypertensive was. And I made the joke, my favorite antihypertensive is fentanyl because it fixes 90% of the blood pressures that I encounter in transport.
Yeah, I think fentanyl is really the unsung hero of that. Because you think about somebody's got a head full of blood. Talk about something that's going to trigger pain in the average patient. I mean, think about how bad the average headache is. But now you factored in when their blood pressure's 200s over 100 secondary to some kind of an intracranial hemorrhage. Sit their head up. Don't leave them flat, and give them fentanyl for sure. I absolutely agree with that.
Awesome. Well, boys, this was great. This is awesome. I think that there's a lot of back and forth that is interesting to hear different workflows. I wanted to ask you guys, though, is there a certain patient population that we didn't really cover. Obviously, we didn't go over all of them, but I went over some of the extremes where people are like not just doing what they routinely do. You know, sometimes you just have an intubation where you're just doing ketamine, rock, putting them on a drip, you know, giving them some fentanyl. So I wanted to go out on some of like the DSI, the really hypertensive patients. Is there any other population that you can think of that's worth discussing?
Yeah. Let's talk about peri-dead.
Oh, yeah, that's a really good point. Yeah. All right, paint us the scenario.
All right. So you get called out for a guy who was macked by a car, autoped, category alpha, critically injured. You get in the back of the ambulance. The first person you see standing behind the captain's seat is the Grim Reaper before you see the fire guys. After you wade past his sickle and cape, you see a guy laying on the cot who is GCS of essentially 111. He has a blood pressure of about 50. He's got a heart rate of 160, and he is obviously dying right in front of you. I actually had this very patient with Dr. the Pet Detective, and the difference is in that particular case, we elected not to intubate because we were convinced that it potentially would be fatal. And that's your immediate impression when you see this patient is, you know, their oxygenation is like 90. They have no blood pressure, heart rate's 150s, 160s, and they're young otherwise. And then they start to puke. So now they've forced your hand and you feel like you're going to have to do something. How do you approach that patient? You know, what's the best anesthetic at that point? What's the best dose? What's the best approach?
I had a patient very similar to this, except they didn't puke. So, but it was a pelvic fracture. Somebody got side swiped and we got in the back, and their blood pressure was 60 over 30. I mean, it was very, very low. And the crew was getting ready that we were intercepting. They were getting all their stuff out to intubate. And it was like, that's the patient that if you take away that negative pressure breathing, they are going to code. They're going to go into cardiac arrest. And so in that case, I'm like, all right, let's put a pelvic binder on. Like, obviously, let's try to get that blood pressure back up. That's what we're doing. But if I'm forced to intubate them, if they're completely unresponsive and their blood pressure is that low and I need to protect that airway, I am very much inclined to do a paralytic only intubation because they are not perfusing their brain. Maybe give them 25, 50 mics of fentanyl or something like that with there. But I want to get the tube. I want to protect the airway. But I also, some of the benefits of a paralytic is preventing them from throwing up. And that's something I need to stop. So if I don't think that there's any chance they're aware, now that doesn't mean I'm not going to follow up with something later. Like I think starting off with the A1 approach where you do pain first, take care of the pain, and then start thinking about adding on the sedatives later. So maybe 25 mics of fentanyl, rocuronium, intubate them, and then if I get their blood pressure up, start adding on a little bit more with that.
What do you think, Mike?
Yeah, this is an interesting discussion because, to be completely honest, I'm not completely familiar with the literature on paralytic only intubations. I know that these things happen, particularly in crash airway scenarios. I think the vomiting is a confounding factor because my initial inclination is an eye gel. I don't even want to intubate this person, attempting alternate airway. Obviously, resuscitation is priority in this scenario, whether, whatever that means. But I don't know. I mean, I think it's an interesting discussion. I mean, even paralysis. Again, it's one of those, there's really not a perfect answer. We know that the patient's going to go with induction. Even though I'm not completely familiar with the evidence, my inclination is to do what Tyler said and to just give the rocuronium at that point and then try to resuscitate them in the interim.
So, right, this is an interesting situation. And, I don't think there's very good evidence. Because how would you randomize a patient like this, right? So there is no evidence that says that if you take a running leap off the helipad in downtown Indianapolis at Methodist Hospital, that you're going to die from that fall to the ground. There's no evidence that says that, but we all know that you're probably not going to have a good outcome doing that.
Right.
So, and lack of evidence does not equate to lack of efficacy. And that's where at some point, somebody's got to stand up, advocate for the patient, say, this is what we're doing because I think it's the right thing. And I think the right thing for this guy is, and I've been coined with this phrase, and I stand by it, is 200 a sucks and an apology. That's somebody that's going to get max dose.
Paralyze and apologize.
That's right. Paralyze and apologize. That's right. And if they tell me when they come back to the ICU to see me that I remember everything about that intubation, I will say to them, thank God, because I thought you were dead. This person is very close to a thoracotomy, right? And in fact, I would probably be prepared to do that. I would have somebody spraying betadine on their left chest while doing that airway, because there's a reasonable chance that they're going to code when you introduce them to our friend called positive pressure ventilation. But you got no choice at that point. You know, I would dump the blood to them. At that point, even if I don't have blood, I dump the crystalloids to them, because you got to get something to fill that space, and you got to try to get them to the OR. That's probably somebody that needs to go direct to the OR if you have that opportunity. And 200 a sucks. Paralyze and apologize, Tyler. What a catchy phrase. But yeah,
I didn't come up with that.
But it's good. It's good. It's got a beat and you can dance to it.
That's right.
But what option do you have at that point? You have somebody who is as close to being dead as you can be without going over the retail price. So you've got to make the best decision you can. You know, it's like a perimortem C-section. You know, at some point you just have to do it because it's the right thing to do.
Mm-hmm. I've also seen patients that their blood pressure is not coming up, and you're like, all right, let's get their map up to 65 before we intubate them. And you're waiting and it's not coming up, and the heart rate's still not coming down, and maybe a little bit, and you're 3 liters in, and you're like, YOLO, let's go. You know, we gotta get this tube. At some point, this is as high as we're gonna get the pulse ox, or at some point, this is as high as we're gonna get the blood pressure. We have to make a decision. At least you're paying attention to it. You know it's a thing. You're aware. You're ready. You got pressors ready to go. But you can sit there. And one time I had a patient who had cirrhosis of the liver, and their blood pressure was down in the toilet. The heart rate was sky high. And I got the blood pressure up a little bit, but the heart rate was still super high. And I'm like, he's compensating for something right now. Like, why is it so high? We gave him some volume. I'm doing an ultrasound. I'm like, all right, let's just wait a little bit. Let's wait a little bit. Wait. And I'm like, finally, we got to do this. Like, he's got enough volume on right now. We got pressors going. This is the best we're going to get. Let's just go ahead and do it. And as much as you try to optimize everything, and it's so important to do, I think it is important to make it not sound like every single patient we intubate, we've gotten perfectly ready. Their vitals all look great, because I feel like somebody who's new in the industry is going to see that and be like, oh yeah, I got to get everything perfect. Don't ignore that. Definitely try to optimize everything, but don't sit on scene for 2 hours in the back of an ambulance trying to get the blood pressure up, because there's a chance, and there's sometimes where you have to go. We got to get to definitive therapy. We got to get them to surgery. This tube isn't going to be what saves their life.
Yeah. And let's be honest, some people just don't make it. That's the reality of the situation. Yeah. I think, again, the key is when your hand is forced, and it would be in this scenario, clearly, the thing that's going to help you reflect on that with any kind of positive notion and learn from that experience is just making sure that you optimized everything that you could. I think optimization is a key word, like you said, Tyler. Did you place a binder? Did you volume resuscitate? Did you pre-oxygenate? Did you, decompress the chest and do all your different, obstructive shock interventions? Did you do absolutely everything you could do? And then if the patient still didn't make it, well, unfortunately, that's just life. But still, taking the steps to do those things, I think, is extremely important, but also expediting and having that forward momentum, because if you're delaying to get that map of 65, they'll never have that. They may never have that. Mm-hmm. Or at least after their after their surgical intervention, maybe they'll have a map of 65 if they make it to that.
And if you're in a non-provider driven environment, you're going to have a conversation with your medical director before you find yourself in that situation. Say, hey, what's your expectation. When we find somebody who's peri-dead, are you cool with a paralytic only intubation? Maybe that's not something that they do in their practice. And if they don't do it in their practice, then they're probably not going to be comfortable with you doing it in yours. So
Yeah.
If you're not someplace where, you have the luxury of being able to do whatever the heck you want, you got to talk to whoever's responsible and say, what's your comfort level with this?
Yeah, no, absolutely. Well, guys, I think this was a great discussion. I'm sure we've got a bunch of people upset or mad or coming back with the, but I think it's a very nuanced discussion, and we all have opinions that we've built over years of seeing patients and coming up with mental models. I love that word. People make fun of me because I say it all the time, but it does. It describes what you see in front of you based off of all the things that you've seen in the past. And I have this talk where I start off with a key and it's starting the car, and it click, tick, tick, tick. It doesn't start the car. And I say, what do you guys think's wrong? And somebody says the starter, the ignition, the car's dead, it's out of gas. There's all these things that their brain comes up with within such a short period of time, because your mental simulation is, when I turn this, the car should start. And then when you notice that something changes from what you expected, you start projecting all these different things. And that's what we do when we see a patient, or we hear that there's a motorcycle accident or something. We start projecting all of the things previously that we've seen, and then try to come up with the thing that works the best. And I feel like that's what we're all talking about now, is how to do the things that you need to do quickly, efficiently, and then get them done. So this was a great discussion. Thanks for coming on. We got Crash and Learn coming up. I'd say put a pitch out there for it, man, but there's no tickets left. So.
Come next year.
Yeah, no. How's the planning for that going?
Oh, it's going awesome. To me, the education is always a priority. I think that's lost. And, that's why, I have a lot of respect for Foam Frat and you all supporting Crash and Learn and our channel, because I think we certainly have the same mission when it comes to just really trying to provide good education to people. And I'm super happy seeing the speaker lineup. We're going to have an amazing, diverse, and extremely beneficial and applicable, list of talks. So whether it's hands-on or lecture, we've got something to meet everyone's bag. So I think those that are fortunate enough to have tickets, I think it's going to be the best one yet.
That's awesome, man. I'm excited. I heard that there's no running water. Is that true?
Yeah. So we will have water on site, but there's no running water. So no showers.
Is there a pond or something?
There are bodies of water nearby. Yeah. If you want to go that route. Yeah, for sure.
Tyler Christofoli, will you be there?
I will be there, and I am camping. I should have done the camping at the one with showers, but I will be camping at the as well. I guess I'm guessing there's not a Holiday Inn anywhere near either. So
when you say camping, does that imply laying on the ground? Does that imply gel on the ground?
No, we're getting a Foam Frat camper, and we're gonna bring the RV up.
Right.
Well, those RVs have showers in them. A lot of them do. So you might be.
Yeah, but I'm still gonna skinny dip in the pond, man. Dan will see my little ponytail, and he'll be like, "Hey, who's that girl?"
It'll be like the shark equivalent. It's a shark equivalent.
Awesome, guys. Thanks so much for coming on. And I'm looking forward to getting this one out. We'll see you guys next time.
Right. Thanks, Tyler.
Thanks, Tyler.